Good afternoon, everyone, and thanks for joining in. I'm Ellen Mason with the California Medical Association, and I will be your host for today's webinar, which is the fourth installment in the Data Exchange Explainer series, How to Optimize Your Patient's Current EMR for Data Exchange. Please submit any questions you have throughout the presentation by using the question box in the control panel, which is located on the right-hand side of your screen. We will go over questions at the end of the presentation. Today's presenters are Jeff Nguyen, Senior Director of Physician Services with the California Physician Services Organization, and Dr. Rachel Cohen, Clinical Analyst Optimization Specialist for Blue Novo. Now I will turn the presentation over to Jeff.
All right, welcome everybody, and thank you for making time for today's fourth installment of our Explainer series. We're excited to have a special guest, Rachel Cohen. She's coming from Blue Novo. And we've partnered in the past on some really cool HIT projects before. And so we think we have great content for you today. So once again, Rachel Cohen is our guest speaker. I'll introduce her in a few minutes before, after I give a quick highlights and updates of our upcoming events, as well as some content we have for you. So, as always, we love hearing feedback from you. And this is all about outreach and education for mainly practices, but also everybody else who's in support of our practices to sign the DSA and comply with the data exchange framework. And so, like Ellen mentioned, there will be a Q&A throughout, be able to enter questions throughout the webinar today, and we'll address the questions at the end. If we don't get to them, we'll definitely follow up after the webinar by email. There will be a post-webinar, and I want to emphasize that today is a CME, so there will be directions in the survey how to claim that CME. So very important to click that, as well as there will be an email sent out to you as well, just in case you missed that little link at the end. As always, we have a special inbox for all your DXF questions. So anything about what's currently happening or you want to share your current data exchange stories and learnings, we are actively seeking out practices to do some informational interviews, and just so we can hear directly from you and your staff about how things are going with data exchange. So today's is about your practice's current EMR. And so Rachel will talk a lot about the common features that will bring value out of the box, as well as some, those who want to invest a little bit more to upgrade, integrate more of that data, and share more of your data as well. Upcoming webinars will continue to focus on what happens in your four walls, optimizing practice workflows for data exchange. And the sixth one is still to be determined. We're going to look at the surveys and see how we're going to end our webinar series. So please, if you have any requests, send it to our inbox or the survey later today. Definitely cannot leave out the plug for the signatory grants. So it is round 2 and fast approaching the deadline of September 1st. So this is a second of 3 rounds of grants for DSA signatories. So for individual practices, up to $50,000 to help you sign up for an HIE or other different integrations like lab, for those who may already are sharing data but want to add more data sources. That is also part of the scope. And of course, training and development for your staff is also included. So please take a look at the application information, and we'll, like I said, we'll keep you updated on round 3, but rather get the application going and get you the dollars you need to invest in your practice. So I'm going to read this. This is part of the CME process. All planners, reviewers, faculty, and staff involved with this activity have no relevant financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients to disclose. This activity has not received commercial support. So our outreach efforts is kindly provided by a CDII, so that's not commercial support. And last note about the CME. So we'll talk about two main objectives today, really about the features that help your practice to comply with the data sharing agreement. That's mainly around making sure that the appropriate data points are shared. There's patient privacy protections, as well as close to real-time abilities to exchange data, to respond to requests, as well as to make action, and also to access information. All right, so with all that, I will hand it off to Rachel Cohen to begin her presentation on EMR interoperability.
Great, thank you, Jeff. And thank you everybody for being here today. We're going to talk about interoperability as it applies to all kinds of EMRs who are certified and have that capability, as well as how that sort of ties into HIEs, which allow for the information exchange to happen because they house that information for the EMRs to access. Next slide, Jeff. Okay, so wanted to start off by saying that it's a good thing to have this data at your fingertips. It just becomes a matter of, what can I utilize it for, and how do I set my EMR up to get more than what, the interoperability capabilities can be. And that's where you would think about what the capabilities that my EMR can offer me, what's free, what's at cost, which HIE is best for me, and they could be state specific and nationwide, which ones offer grants. There's a lot to look into and think about, and the questions really boil down to, what do I want to get from my EMR? Like, what am I looking to get in order to close gaps in care, create a circle of care for my patients, and give the best possible care that I could get with the data at my fingertips, and then do studies, or there are a lot of other things that could happen as a result of the data that you get, which make it a wonderful thing because it is pretty easy to get and access. It's just about configuring. And while doing all this, considering the patient's requests and their privacy as well. All of this are capabilities within your EMR. It's just a matter of figuring out who, creating a team to carry it out, and then moving forward with the actions that your EMR is capable of. Next slide for me, Jeff. So I kind of wanted to give you the definition of interoperability. And I gave you this nice, big, long verbiage here, but I wanted to sort of break it down in layman's terms and say, okay, so what's the difference between like the interoperability portion of it and the HIE? Is that the same thing? Like a lot of people ask the questions about, doesn't that mean the same thing? The interoperability exists within your EMR. There are capabilities that allow you to exchange data and then utilize that data. That's where the difference between the interoperability of your EMR versus the HIE itself, which is the place that houses data, the companies. They often call them HINs because they're health information networks that you would join to get data, and depending on what kind of data you're looking to get. The EMR has the capability, even without an HIE, to get data. It's a matter of how granular you want to get. So I said in the slide, the interoperability refers to the actual exchange of the data, and then how you use it, how do you utilize it within your EMR. The capabilities are separate of the HIEs because it's, how does that come into my system? Am I using, an HL7, and you could get real technical with terms, or FHIR to look at it? Does it come in as just a stock document, or does it port right into my EMR? And each EMR really varies in terms of their technical components and what they can offer you. And that also depends on what are they offering you for free versus cost. So I kind of laid out that you can get the data, within your system through queries. You can get them as documents. They can stream directly into your EMR as alerts using HL7s or FHIR. But these I laid out on the right-hand side. What are the particular types of data that I can get? What does it look like? And how am I able to get it? How does my EMR get it? And we're going to dive a little deeper and break that down in the next couple of slides as well, and give you really good examples of just random EMRs that kind of show you what does it look like and what do I see. Because it's, when you're starting to talk data and you're a clinical care person, You don't want to know the back end of how it gets there. You just want it to show up and alert you. And then what can I do with it is your next question. Next slide. So the interoperability, again, is kind of like, if you think about, it would be really difficult if we had a Verizon phone and it only spoke with Verizon. The interoperability within your EMR allows EMRs to speak to multiple different EMRs and connect to, different housing agents or RIOs or HIEs that facilitate this data to go, in any kind of EMR that's certified to do this. The interoperability portion is allowing you to have Verizon and talk to somebody that has AT&T because the data goes back and forth. Or even sending a letter to somebody, right? And I speak English, I send it to you, it shows up, and you speak French. How are you going to use that data if it only came one way? There's standard verbiage, standardizations in how it gets to you, and standard ways for it to enter your system in order for it to translate properly and allow you to use it. That's all the technical back-end stuff that your IT would typically connect with and worry about. You're more concerned with, can my system do this? And what do I see when it comes in there? And a lot of times it's doing it already and you're not even realizing, like if you've connected to a lab company like LabCorp to get lab results, if you're sending immunizations, that's all part of your system's interoperability because there's standard ways for it to get to you. SureScripts, tokens, those are other ways that your system's already performing interoperability that you didn't think about. But now, how do you get more data and how do you utilize that in your system? It can do so much more, and that's where you would find out what your system could query automatically and how maybe connecting to an HIE can facilitate even more granular data for you to look at when it comes to your patient care. Next slide. Obviously, it's beneficial to get the data, because you say, okay, well, why do I need to do this? My system does, a certain amount of it. You can get a lot more, particularly with finding out what your EMR can actually do, what kind of tools it has that are free versus things that may cost something in terms of connection. Even a lab interface, depending on how many labs you send to somebody, there's a cost for it, right? But so what's the point of doing this or connecting to an HIE? It's why you became practitioners in the first place, is to give the best care possible that you can to your patient by reducing their healthcare costs, by looking at, situations that could be emergent, by connecting with other providers, and that helps you to improve your care coordination, that nice circle of care where we're sending a patient off somewhere, what happened to them, but now we can see, or they got a change of medication, now I'm able to see. And at the end of the day, it also improves the patient's experience because they have providers talking to each other through their EMR systems that allow for no miscommunications to happen. Sometimes they're laymen and they don't understand necessarily that, that something happened to them, and it gets lost in translation. I can tell you from a personal experience, it happened, with my mother's husband, who didn't realize he had a myocardial infarction, but if the providers were able to sort of talk to each other, then he'd get a better, from his primary understanding of what that was. So I like the idea that we're closing the gap and allowing for this circle of care to happen all through the transmission of data that we're sharing and we're able to access, both through our EMR systems and through the HIEs available to us. Next slide. And it's touching on, again, what I'm saying, that whole idea of care coordination, making sure that we're closing, legally our gaps of consenting to treatment, consenting to transfer of care. Alerts is a big one because we're always looking to see, this patient needs to come back for something. The more data that we get to know that we've given them a referral out to do something and they've gotten something done, now they need to come back. We're able to see that, able to query, and some queries are available within your EMR, and gathering data, even at no cost. But we're trying to overall improve our patient care and the clinical, business, administrative processes and everything that we're doing as a whole as an organization. So the more we can get out of our EMR, the better care that we can give, and the better, our profits are even as an organization too, because we want to be able to give patient satisfaction, have a patient come back and continue care, and also make sure everything's appropriate. Next slide, Jeff. So then the next question becomes, all right, I like this. This sounds great. I'd like to know what can my EMR do for me? What capabilities does it have? And then how do I partner with an HIE to get even more granular data from my EMR? And I think this requires kind of understanding what do you want to get out of it, and look at what you're trying to achieve. Is sort of the first question you want to ask yourself. Every EMR, regardless of whether you're on Epic or you're on eClinicalWorks, they all should coordinate with you and have a strategic account manager who's supposed to assist you in your journey of using it. They're getting licenses and you're giving them a lot of money to use their EMR. So leverage your strategic account manager to find out first and foremost, what capabilities does my EMR have? What do we have within that we can use for free? What's something that I would purchase and what's the benefit to me? And then what HIEs are you connected with already that may be at no cost or with grants would allow you to leverage that funding? And then what are other options that my state has? They'll be able to tell you based on the capabilities of your EMR what it does, as well as a lot of them partner already with a particular HIE. So that's a really important question to ask. And there's generally someone in your organization that sort of meets with them and should meet with your strategic account manager. Then you have to determine what services are available, and then choose one. Obviously, you'd go through what suits your organization best, what the needs are, what data you're looking to get, and why. You would have an agreement, do a purchase agreement, and this is all stuff your account manager should be helping you with. Then you would look to configure, and generally the vendor and IT would handle, like, what's the capabilities that my system has? Are we set up to do HL7? Can we have FHIR? What files need to be dropped? And what data are we going to share and look to acquire as we connect with a particular HIE? And so you're going to have to sort of govern what's going on both with your vendor and also within your organization, prepare for that change, which is now you're going to integrate. So evaluate, partner, onboard, and then you get to this integration process where you've decided who you're using, you've set your system up. Now you're going to use some sort of public registry, and there's got to be, some management and training within to understand that now we're getting this data, how do we utilize it, and benefit from it, and sort of the staff, it becomes part of all of that too. And you would probably want to consider an analytics type team to look at the data so that you're taking what's given to you and setting it up in a digestible format for you to kind of review on a monthly basis as well. Next slide. A lot of questions I get is, what data is being shared? And I kind of wanted to lay out a list of what you're seeing. Usually it's anyone connected to the HIE is agreed to share their data as well. So it's not just you procuring data and getting data. The minute you join an HIE, you've decided to share the data that you have. So what is that data? Long-term care plans, assessments, all the current medications, the orders that you're doing, past procedures. Generally, all of this is part of your charting anyway. You're sharing your CCD, your historical pathology, any kind of telehealth you're doing. Sometimes trackers are involved in there. They're basic information, claims and referrals as well. And that's why we'll talk about, like, when you decide to join, like what the opt-in for the patients will be. We'll discuss later on in privacy. But this is the data that you are sharing and the data that comes to you as well, which is really helpful in kind of understanding a full circle picture of your patient and what's going on, who's seen them, if they're getting care outside. I know I'm a horrible patient because I'm supposed to go to the doctor for things and I never go. So I think it would be good for somebody to see my picture of what's going on and understand, what I have done and what you need to do as a provider by having this information in front of you is really nice. Easier than thumbing through paper, of course. Next slide. And this is good too to understand that you're sharing this information in the HIE within your system, whether you're using, leveraging your EMR's capabilities as well, but not just anybody can see that information. And this boils down to the security settings of any EMR that you're on, and there's generally a team that owns that, and it allows for doctors to see what they need to see, nurses to see what they need to see, and generally when it comes to information shared, it's drilled down by security setting as to who has access. Not just anybody has access to it, It's going to be generally for clinical care. A lot of what's ported in goes right into a progress note or patient documents, and not everybody has access to that anyway. So it's sort of a safety in that even your EMR itself is set up a certain way, and the HIE sort of adheres to those particular permissions or roles within your organization. So not just anyone will have access to it, which is nice. It protects you as the entity, and it protects the patient as well. Now we'll talk about like the exchange that sort of takes place. On the next slide, Jeff, we talk about alerts. So you get this information, right? And every, I didn't want to make this specific to any EMR because all of them that are certified have this capability to not only exchange data, but to get data, actively within, and it will alert you. It will show up in the system showing you, and they all call it something different. Some of them call it P2P, some of them call it EHX, some of them call it CDA, clinical document viewers. There are different ways that it will come into your system, and I think it's just about learning how in your system. You can turn things on, and that's wonderful, but if you don't understand where it goes and how to utilize it, that's sort of the next challenge for you is yes, I got this data, it's great, I connected to it HIE, now where do I find it and what do I do? And often that's a question that your super user at your practice should be able to help you to understand and guide you through and do constant training on it. I showed you a CDA viewer, which is Consolidated Clinical Document Architecture from NextGen, is one of the companies that uses Mirth to pull in data. eClinicalWorks not only connects with Prisma or certain HIEs like Commonwealth, but they'll come in as you query, in its actual query, they come in through an EHX viewer, and they allow you to view documents and certain histories. When you connect to whatever HIE you're using, you can get even more granular. And the next couple of slides will sort of show you like the difference between that. The next slide, Jeff, is the CDA viewer from NextGen. And again, all EMRs that are certified have this capability. It just looks different in each one. Their consolidated clinical document architect structure, there's actually several things that NextGen allows you to do for free. And the information will pull in without even having to connect to an HIE, but you don't get as much granular information. Like you can get a problem list, allergies, meds, vitals, care plan, and you can print that. Some of that will port in as actually a document, like an XML document, and you can print it, right? So it doesn't allow for everything that you want to see, and that's where you have to decide that, is this good enough for me to print as a document and then I look at it before I see my patient, or do I need more and do I want it to port into my note as an actual alert? NextGen does offer, a download my records. They use like an Amazon cloud to allow you to have actionable data that goes into your EMR. Epic does as well, ECW does as well. They all have like two options. So I think it's about like understanding what's best for me, and if I'm connecting to the HIE, then I'm using the most granular data, and I'm getting more than just a document. I like the idea that it talks to my EMR and goes somewhere that's actionable. The next slide actually will show you the same sort of equivalent in ECW. It's a clinical summary that goes in there, and you can print it out and sort of drill down, and it'll give you information. Like we blocked out information because it was me that was the patient up here, but the information will port in based on a query that comes in there, and it's limited. So it's limited. It allows you to view it, but it doesn't port into your EMR as sort of like part of the problem list, which is what you want to do. And I think that's the decision that you sort of make. Hold on one second. And so the next couple of slides are an example of connecting to your HIE, where you can get a little more granular and then utilize that information and port it into your EMR. And it shows you sort of an alert. And that's what I think most people are looking for, and they just need to decide like what's best for my practice. Obviously, leverage what you can for free and test it out. Each one looks a little bit different, but I think that the benefit comes in having actionable data that you can see that's alerting you to do something. And the more granular it gets, the better. It's the difference between like understanding that a patient got something filled somewhere versus had scripts written that he never filled, is the difference between like the HIE portion of it. It's just getting 2 or 3 steps more granular and allowing that interoperability within your system to do more. This is an example of the third-party exchange that comes from Prisma. And I wanted to show you this so that you can understand some questions that often I'll get about HIE is, I can't filter. How do I see? But you can. You can actually change. And each EMR has a different way to do it, but they absolutely have ways to filter. You can do it by the record itself, a timeline. You could go to a specific provider and see something. So you can make it so that you don't have to filter through or kind of search through, so to say, lots of data that's in your face. Maybe you're looking to know that this person had a mammogram or went and got a pap somewhere. You can absolutely filter those things and drill down. And that's sort of the difference in getting that data that's housed in those HIE warehouses and really getting granular, because your system is now allowing you to do that. The next slide, I think, is also a picture of some more drilling down, even from a timeline. Maybe you don't want to see, 2020. We want to go back and see something else, or see a specific month where the patient knew they went somewhere, but wasn't entirely sure, like everywhere they went, or forgot. Like with our elderly people, I think this is super helpful because they know they went somewhere and got something done. They weren't sure if they got a test that you ordered, and you want to make sure. And again, that whole idea of circle of care allows you to get the provider that they've seen, where they went, the timeline of it, anything prescribed. And so I think it's a really nice way to sort of search for the data and get it. It's just a matter of, I think, getting used to how it's coming into my system. Now, the next slide, actually, I'm going to go back again and talk to you about, well, okay, great, Rachel, goes in there. Where does it go and how do I see it? Each system, doesn't matter what it is, will have a notification for you. And that's going to tell you, it sort of pops up in your face. Now, I think what everybody would love is the minute they log into the patient and a big giant alert pops into their face, but I don't know any EMR that does that. But knowing where the data goes in your system, and that's just a matter of learning, where does it go in Ally? Where does it go in NextGen? The super user should know all of your tabs and where things are sent. And once you connect or even query, not necessarily connecting, even if you query, an alert that happens that comes in will come in either through, like I gave some examples, there's a little red exclamation point where the EHX is. In the NextGen, your alerts would turn red. Even if you have a progress note and you're using an HIE, the Prisma shows up at the bottom with a number. So it's always going to alert you that, hey, this person maybe went someplace else. You may be interested in that data. You want to see it. And so it will turn red. Usually they turn red. There's usually red or some kind of exclamation point that's alerting you that there's some sort of change or some new place that your patient went to. So you're never going to have to like search all over for it. It's just a matter of, oh, this tab turned red. I need to look at it now. And then you can go through the data and get as granular as you want to with that. The next slide will show you too that, like I discussed before, when I'm in Prisma, I can choose how I search for something. I can go to a particular record timeline. I can look in Prisma for a provider. In NextGen, I could filter within the last 30 or 90 days or search with a current type of provider. So there's always ways to filter. Each system does it a little different. I'd love to say I know all the systems. I don't, but they all have that capability. It's part of what they need to do to be certified is allow you to find something, allow it to come into your system and alert you and give you a way to filter so that you're getting a lot of data, but you're looking for one component of it. So they all have different actionable ways of doing it, which is really nice. It's just a matter of learning your system. And again, your super user or your content expert at your facility should know the system inside and out to tell you. They're going to learn that, oh, okay, now we've connected to our HIE. Here's how we get data. And that sort of trickles down to like learning for everyone, providers and staff, like your medical assistants should know as well. So then we want to talk about the next slide, which would be obviously you want to make sure we're talking about data that's coming into your system, and the patient needs to be made aware of it, just like, the HIPAA and them signing consents and transfer of care, all the different things that your patients need to sign for. They need to authorize you getting data. I know there's some systems that I work with that before you can even collect the data, like I want to go and do a pull of their medication, it's going to ask me before I can even do it, what's their eligibility and do they consent? So the system generally will have an alert automatically in it. However, you have multiple options for asking the patient, do they want their information shared? And you always should. And a big part of that is, how are they opting? And that's a consideration that you make more so when you're joining the HIE portion. And the next slide, I just want to discuss a little bit because I think people get confused. Jeff, you could hit the next slide. You want to make sure you're capturing consent. And I don't want there to be confusion around opting in and opting out, because a lot of people think, oh, the patient opted in, so they're okay with getting data. And that's actually not the case. You're going to decide, and you'll get granular in terms of they opted in with restrictions, opted out with exceptions, right? But opting in actually means that the HIE doesn't have any data on this patient until the patient gives permission. So don't get it confused. I think that people do often get confused and think, oh, I told the patient and they opted in so I can send the data. No, actually you can't. You have to now specify what data do they want going over, and you have to ask every time you send or, do a lab. It's more so the opt-out and making the patient understand, because the patient would get confused if you said opt-in, opt-out. They would think, oh, I opt out, I don't want my data exchanged, when actually it's kind of the opposite. If they opt out, their data automatically goes to the repository, which is the HIE. And if they don't want anything going for a particular reason, like a lab result or, a private test at a psychiatrist or something like that, they actually have to explicitly request for you to not store their data. So I wanted to clear that up and make that very clear, because people kind of go through this quickly and not quite understanding that, oh, we say opt in, we put it in our system, that really when they're opting in, now you have to make sure you set aside an understanding of what data can and can't go and ask every time, which, like I said, for some systems, they do that automatically anyway. But opt-out, you make very clear that their data is there unless they're specifying otherwise. And there could be like the following, the opt-out with exceptions, allowing the exchange of certain data. They can do that. Like, oh, I want all my labs to go, but my personal private psychiatry history, they may not want to go. So the stuff that you determine and you want to make sure is in your EMR one way or another. So some of them you can hit the next slide, Jeff. Some of them will have automated ways, like I explained in the EHX, or if I want to search for a patient's medication history, some of them are going to ask me before I do anything, did you get consent? And that kind of stays on the back end from an IP perspective. But all EMRs generally have some way to consent, whether you have a built form or question. A lot of them come with questions if it's mandated by the state to ask. Here's an example of eClinicalWorks has a structured way to build it. Most of them will always give you an option somewhere in the system, whether it's in the demographics or you put it in HPI. Where you put it is your choice. There should be a form that they signed and some kind of structured data within your EMR that says this patient opted in or they opted out. And what are they opting in and out for? And you can get granular and specify, well, they opted out. They know their data is going over, but they want no psychological data going. You would, put that in there as well as you're entering it for the patient. Also nice to know on the next slide is that you can give this to them in multiple ways. So your patient could choose whether they're opting in and opting out. And again, making them understand what that means. If I'm a patient and I didn't read, what that meant, I'm going to say, oh yeah, I opt in, send my data, when they're not really sending any data. So make sure you educate the patient as well. What's the difference between the two? So that you can either go back to that last slide and structurally put something in, or utilize consent forms that are stating, hey, our organization is connected to an HIE, your data will be shared. Do you consent to that? You could do that on a kiosk. Most EMRs, we have kiosks nowadays, tablets. touches that they could do in office. I would say a majority of our EMR applications also utilize a patient portal. We use that for a lot of our communications. Your next appointment this is your lab result, but also for consents that they're accepting. That's a nice modality for the patient in the privacy of their own home to, consent or not consent to something. But again, I would make it very clear, a clear understanding of what that means when I build a form for a patient to consent to their data. And then the next slide, again, I showed you some structured questions that also are pre-built into NextGen as well, which is the same idea of no matter where it's put in the system, I've built this question and I've clearly stated it to my patients so they understand. So sometimes verbiage, just the same way you would use a scribe and say, hey, I'm scribing for my provider, the same concept around how you're building this structured consent somewhere in your system. All systems, all EMRs have a way for you to build stuff. It's how we take the out of the box and turn it into something more specialized. So it's just a matter of where do you want to ask this question? Are you asking it on the privacy on the kiosk? Is your front office person asking it? They may do that in demographics. Or are you asking that somewhere in the chart? Your medical assistant may do that in their pre-check, evaluations of patients before the doctor gets in the room. And you would have, a form that you can scan in or that structured data built into the system. So there's always a way to do it and a way for you to decide that this patient consented to that, opting out with specifications or opting in and they don't want anything going, and you just clarifying that. But the systems also allow for you to do that, which I think is great. So you're covering yourself. You're, just explaining to them that the benefits of them having the data in the circle of care. Most people don't care. They know that their information's going somewhere, and if it benefits them from a healthcare perspective and allows you to talk to other providers and give them the best care possible, most of them think it's a good idea to share that data. Next slide. Some other additional opportunities outside of just what you would think come out of the box is, I love trackers, fitness trackers, but certain medical devices could speak to your system. And these are things that most people don't even think about because they're so honed in on that progress note data and problem list. But really nice opportunities is automation and scheduling, patient education at their fingertips, immunization registries, which most pediatricians, their systems do automatically. Syndromic data that you're going to look at. Here's just a sort of a list of all kinds of opportunities that you can get by utilizing the interoperability within your system and connecting to HIEs to do so much more. All of it lends itself to, better care for your patient and, a better idea of what's going on overall with patients and how they move through your EMR system and through the community. And the last slide there is if we have any questions. I hope I stuck to a good amount of time and made this clear for you all. I guess we'll open it up. Jeff and Ellen.
Perfect. Thank you both so much. We did receive a couple questions. Here's our first one. Do I need to have an EHR or an EHR that can do data exchange to comply with the DSA?
I'll take this one. So the answer is no. So this is a common question we get. It's a good question. So the DSA does not specify any particular technology. So many of our other experts have said, it's rules of the road. So you do not need to have an EMR. I think definitely we lean on having the best technology for the best care. So as of today's speaker, hopefully demonstrated, there's a lot of benefits of having EMR for both your practice's efficiency as well as the expanding your capabilities to get as much information for patient care. So back to the question, no, you do not need to have the EMR to comply.
Perfect. Our next question. When will the QHIO list be ready so I can see which one will work best with my EHR?
I'll take that one too. The QHIO, so the Qualified Health Information Organization, and so I'd assume the asker is referring to maybe possibly the grant, the QHIO grant. And so the QHIO organizations, or those who want to be a Qualified Health Information Organization, need to apply So the application is in development, and the expectation is that it will be released in September, if not sooner. And our kind of governing program agency, CDII, will be working very, very hard to review those applications and get it out as soon as possible, so about 4 to 6 weeks after they received it. And related to the grant, so there is 2 tracks to the DSA signatory grant. One is that QHIO, the other is a technical assistance. So just a reminder, you do not need to select a HIO or QHIO to apply. So please, you can fill in TBD or your preferred, all right? And the grant support teams will know what you're saying. So please do not believe that it's a requirement to select a QHIO to apply for those grants. But like I said, the applications are still need to be developed and reviewed, but we'll definitely keep everybody updated on the progress of that process.
Great. Our next question. How do you participate without an EMR?
I have an answer, Rachel, but I don't want to say something that's out of turn if you already have a response.
You can, Jeff. I'm on the other side of that, so that's great. Thanks.
Okay. So we've at CMA have really tried to do our homework on the different HIEs. So I'm interpreting participation as how do I get this data if I don't have an EMR or my EMR is currently, there's a lot of barriers to get it to connect. Many, if not all, of the California HIEs do offer a portal access. What does that mean? So your practice would have access to your patients you have to look them up on an online website. So they're all the same types of privacy protections that Rachel reviewed will still apply, all right? So what don't you get? Obviously, you're not getting the data ported back into your EMR, so it is more limited. But but I think there's still value, right? To what kind of the value that Rachel mentioned about coordinating care. So, for example, going on to a portal, an HIE portal, to look at any recent ADT information. The most of the HIEs I have and my team have spoken to, there are alerts that can be pushed out. So to your practice's email saying there's information about your patient that is new, that's worth looking at, and you can click it and it'll take you to the portal and to the exact record or the exact information that the alert was talking about. So like I said, it is not as seamless and elegant as some of the features that Rachel mentioned today, but it can be worked. And like I said, there's value there as well to be with an HIE with the portal.
You could also, Jeff, too, there are like third-party companies, and it's always at a cost, but they do have like data warehouses, and then you get very raw data, and you kind of need someone to take that data and put it into tables for you that's digestible. So that's, you can always, there's always ways to access the data. It's just about the convenience of how it's coming to you.
Oh, thank you for that. Yeah, I didn't know that alternative.
Great, thank you. Next question. Do single independent providers have to participate? Are there any exempted groups?
So I'll take that one. And so from a participation, I'm going to interpret that as the data sharing agreement. So there is no exemption for small, medium practices, independent practices overall. There is a different deadline to comply. So for smaller, medium practices with less than 25 physicians, the deadline to comply with the data sharing agreement will be January 31st, 2026. So there's a difference in timeline. However, signing the DSA due date was January 31st, 2023, and to comply with the agreement is in January 31st, 2026.
All right, our next question. Does having next gen or ECW EMR with connectivity to Commonwealth Alliance / Care Quality comply with DXF PNP?
Jeff, I think that does. That's the whole point of it.
So Rachel, clarify with me, are those more out of the box, like the care quality? Is that out of the box?
No, the care, it's not out of the box. You still have to do that whole idea of speaking to your account manager and getting connected. I know, like from ECW's perspective, they partner with Care Quality and Commonwealth, so it makes it a lot easier in terms of the integration and the setup. Like the technical parts are so much easier with certain vendors because they partner with people because they're already prepared to do this. And that's why some of their interoperability features do it without even connecting to the HIE, but there's more advantages to doing it, more data to be had. So it's kind of like there are some features that are out of the box, but that more granular data that you're wanting to get that step beyond is something that you would need to have an agreement for.
Okay, thank you for that.
And I do think it's worth it.
Yeah. So I think for the ease, the efficiency, although it's not like just flipping a switch, but at least it is the pipes are there to connect. Let me answer that question from a implementation, and I think about the integration little blue arrow chevron that Rachel had. There's the technology part, which definitely takes a lot of work and sweat equity to get set up. However, there's also the kind of like the non-sexy discipline of policies and procedures and training that when I think together, well, this is where I cannot say 100% it'll be a practice will be in compliance because we're all human, right? So we need to stay disciplined to follow our policies and procedures. And I think that the rules of the road, the data kind of data exchange framework is really kind of saying that all folks who are sharing human health services, let's all follow these rules of the road. He's not saying that there will never be areas of improvement and mistakes. So that's why I say I want to say I don't just kind of just turn it on, configure it, and set it and forget it. No, I do not want anybody to leave this webinar to feel like that's all you need to do. No, I think this is what's like everybody day in and day out. There's different patients. There's different experiences. So it's about being vigilant and on top of these different policies and procedures, which I would say, are not new for many practices. So this is just a chance to kind of just relook at the HIPAA guidelines, relook at what's in your EMR, relook at the language. Maybe you've posted something about patient consent in your exam rooms or your waiting rooms. Should I update that? Should I refresh that? Right? So then once again, the technology is one piece, right? It can get you things easier, faster, but if you're not applying the policies and procedures, then it's not going to help you at the end of the day. So once again, it is just barely half of the battle. I think most of the battle is to really stay disciplined and on top of it. I know that it is not sexy work, all right? But that's what I want to underline that for those who are attending today, I believe you are putting that effort. So please continue with that engagement.
Here's our next question. Are there penalties for doctors who plan to stay on paper charts for not publishing data?
As of now, there are no penalties. And once again, let me connect that question about EMR being a requirement. No, it is not a requirement. So that in itself is not a penalty, and it's not like hiding anything that there will be penalties later. As of now, written to the policy procedures, it is, and in our FAQs, and it's on our CMA DXF website. you can see the verbiage that the state has provided as well. So that's a base. You don't need EMR. The penalties. There is no penalties currently about not signing the DSA or abiding by the policies and procedures. CMA does not expect anytime soon there will be a lot of public comment process, and CMA will definitely continue to keep everybody updated about what is coming down the pipe, so everybody get prepared. About the policy and procedures where I want to highlight the most is about real-time data sharing. Real-time sounds like, I think in this day and age, is like instant. I don't think the intent is that, like, somebody like a specialist is requiring of a primary care some notes or vice versa. It is not the expectation to be instant. It is about sharing the information or the lack of the information in a practical timeline, a service level agreement type of turnaround. So there is no penalties around that. I think right now we've talked to a few practices, just kind of digging into what they do today around data exchange. And every single one of them is saying, I still fax. It's not going to go away anytime soon. I know that we poke fun a little bit about the fax. However, if it gets the job done, and if the folks, and you could be one of them, are not sharing data electronically and still rely on fax, do it. The intent is to follow the policies and procedures and not endorsing a particular technology. So I know I'm gonna live my soapbox about that. I don't want to come across that, what good care looks like, what efficient practices in your practice looks like has to be the same. I think it's the outcome, right? So good clinical outcomes, great patient experience, no burnout with your staff. That's what it's all about. Not about saying you got to be on an EMR. So I'll get off my soapbox, but please, for those of you, the practice who are still on paper, it is not against the DSA or data exchange framework to continue to be on a paper medical record system.
All right, our next question. Can grant money be used to hire staff to input patient data into an EMR?
Interesting. Rachel, I know you had mentioned this one when we were talking back and forth about the content about onboarding and integration. Can you first kind of maybe give a little bit of color to what that looks like? Because I know you had mentioned about updating charts and things like that. So what that process might look like if
I think as you organize, what it is you're looking to get from the integration, and then obviously leveraging the grant money, how are you utilizing that grant money? I haven't seen like that they've specified it has to be used for this, that, or the other. So I think it's a matter of like almost like a proposal that you would be making and sort of sharing like, okay, this is what, we're looking to do with this. We definitely want to utilize what's in our EMR, but we just don't have the bandwidth or the manpower to do it. So I don't see there being a problem in that. I think it's more of like you creating like the framework for like, the why I want to do it. I haven't seen yet, Jeff, anything that says they have to spend that grant money in a certain way. And certainly if your intention is to hire people to get you to utilize it better, that's kind of the point of all the grants anyway. But I can't say specific. I just personally haven't seen specifically them tell you if they're allocating funds how you have to use it. And so I would say that's actually a great way to utilize those funds if you're getting them, because the point is that you're getting data in there that can be used.
Yeah, and I can try and find out. I'll follow up. Yeah, I'll follow up formally about the purpose of that. So from the grant perspective, it's nice. There's really only 4 milestones, right? About contracting with the appropriate vendors, doing the setup, exchanging data, doing the training. Roughly, those are the 4, right, of the broad milestones to complete. So back to the question about inputting data, right? And I think there's probably will be some data input. So I would say that an example that I've heard is pediatrics who are behind on updating their registries, vaccination registries, right? So prior to data integration, spending some more time, overtime to go ahead and get caught up. I said definitely write that in, because that's what Rachel has said, right? It is about getting ready to do the data integration, and so that that support or that the additional hours to actually digitize some information so it can be ready to be shared. That definitely sounds to be in scope, but I'll definitely verify that and then send it out to the audience who attended today.
Yeah, I'll check too, because I believe that's part of readiness anyway. So
Perfect. Here is our last question. Where can I check to see if I've signed the agreement? I'm one of those small solo practices.
All right. So there's two ways. One is to go to the CDII DXF website, and there is a spreadsheet, right, that you can look for your name, your organization's name on there. The easier way is just go ahead and email the DXF questions inbox, and I will look it up for you. So that'll be the easier way. I enjoy data and spreadsheets, and I look at that thing every single week. I hope to see more and more of your names on that sheet. But if you ever are in doubt or want to say, can I see that? It's public information, right? So there's nothing, like I said, that isn't out there already. But for those who may not be as savvy with Excel and filtering, things like that, I'm happy to help. So once again, dxfquestions@cmadocs.org.
Great, thank you.
Ellen, thank you for the facilitating all those questions. I just have a couple more closing questions before we end. Is that all right if I kind of review those?
Absolutely, take it away.
All right. So once again, our next webinar explainer series will be in 2 months in October, and we're looking to provide more of the practice level examples. So less of us folks who are a degree or two away from provider practice offices, but maybe some great bright spots we want to share. So you can sign up at where you sign up today at our CMA website. Once again, please check out the DSA signatory grant. There is actually a redesigned website. Here's a link here that will just be totally focused on just the grants. And lastly, we'll continue with the theme of hearing from you and all these great questions. We need your feedback about what you need to exchange data, if it's to enhance your current data exchange, if it's, if the grant money covers just so much, how do I get other funding? We're happy to help and talk to you about how to optimize data exchange for your practice. So thank you, everybody, for your attendance today. For those who are claiming CME, please kind of don't close out everything and X all the pop-ups. There will be a survey link sent after the end of this webinar and also emailed out to the attendees. Thank you.
Great, thanks again to both Jeff and Rachel. We did record
Thank
today's
you too,
webinar.
Ellen.
Yeah, absolutely. We did record today's webinar, and it will be available on demand on our website tomorrow with a link to download the slide deck. All of our upcoming webinars can be found on the CMA homepage or at cmadocs.org/events. Our next webinar on Tuesday, August 22nd is Demystifying the Medical Staff. Recordings of past webinars can also be found on the CMA website at cmadocs.org/webinars. Contact us at events@cmadocs.org with any questions that you have. Thanks, everyone.